Good day everyone at the Pan-African Congress of Radiology and Imaging in Nairobi. My name is Dr. Rahel Kasamali and I'm a Specialist Registrar in Interventional and Diagnostic Radiology in the UK. Firstly, I'd like to apologise for not being at the conference in person. I really wanted to be there, but as my FRCR exams are fast approaching, I wasn't able to make it. However, I'm really passionate about forming training links between the UK hospitals and other hospitals across the African nations, and therefore I've put together what I wanted to tell you about in a video presentation with the hope of connecting with all the attendees there and forming a communication link between myself and yourselves. To tell you a bit about myself, I'm a fourth-year radiology trainee, subspecialising in interventional radiology and abdominal imaging. I currently sit on the panel for the Society of Radiologists in Training, and I'm also on the committee for the British Institute of Radiology. I'm really passionate about medical education and spend a lot of my time teaching medical students, and I'm currently involved in the development of the medical school radiology curriculum. I'll now change over to my slides, so you'll just hear my voice in the background, but hopefully you'll still be able to pick up all the content with just my voice in the background and these slides. My talk today is entitled Comparing Specialist Radiology Training in the UK and Africa, and I'll be telling you the UK perspective and also what can we learn from each other. And during this talk you're going to hear about the UK perspective on training. However, I really want to hear back from you to understand the perspectives of training from your respective hospitals, as I feel that there are definitely links that can be formed in the future. Worldwide, the demand for radiology services is increasing exponentially. At the moment, radiological imaging is sitting at the centre of modern medicine, and therefore the requirement for excellent radiologists is really imperative. In the UK, there are increasing numbers of attendances to the hospital due to the ageing population. There's constantly a wider range of imaging investigations available, and there's an increased demand for interventional services, and what that means is the demand is continuously going up. To give you some figures, currently approximately 42 million investigations are carried out across the UK, and this has grown by about 26% over the last 10 years, with the biggest increases occurring in CT and MR imaging, and these have had rises in excess of 80%. So with an increasing number of investigations, it means that we require an increasing number of radiographers to acquire excellent quality images and an increasing number of radiologists to report these images and get the right diagnosis. From this graph you can see that the number of radiologists per 100,000 population in the UK is one of the lowest in Europe, and I expect that this is still a stark contrast to the numbers that we would see across Africa. I recently read a paper stating that there are only about 10 to 15 radiologists in the whole of Mali in West Africa, and all of these radiologists are centred on the capital city, so access to radiology in the rural areas is very difficult. So it'd be very interesting to compare and contrast these numbers. The Royal College of Radiologists have put together a plan to increase the number of radiologists in the UK, but it still remains an incredibly competitive speciality to enter in the UK. There's approximately 200 training posts per year. However, there are in excess of 1,000 candidates applying, so I feel like I'm in a very privileged position. So why have so many of us at today's conference chosen a career in radiology? So some of you may know the person in this photo here. It's Dr. House from the American TV show. He's a diagnostic specialist who's involved in radiological imaging and really shows how important radiological imaging is to the rest of the clinicians. And essentially, what I'm trying to say here is that radiology is just starting to become a bit more of a cool speciality. It's no longer just looking at scans on light boxes. It's working with cutting-edge technology, being involved in interesting diagnoses, having diversity in your job plan with loads of different modalities, being able to work internationally, having an endless supply of ongoing learning due to the rapid development in their speciality, but also having the bonus of a good lifestyle if you choose to have that, as we're not directly looking after the patients on the ward. The way that the Royal College of Radiologists in the UK have made radiology training a little bit more competitive is by changing the route into radiology. Traditionally, clinicians used to have to complete their foundation years of training and then go on to do 2 years of either medical or surgical training, completing their MRCP or MRCS prior to entering radiology training. Now things have changed so that doctors only have to do the 2 foundation years, and following this they can apply directly into radiology and enter a 5-year run-through training scheme with no further applications until they've completed their training, and then go on to become a consultant radiologist and can practice independently. This is quite different to the other specialities where there are multiple rounds of applications, meaning that the training can often be slowed down. Across the UK there are 18 different training schemes that are geographically positioned across the UK, and they all are regulated by the Royal College of Radiologists by following a specific curriculum. However, each one does have different methods of teaching. The majority follow the traditional apprenticeship model where trainees are placed in hospitals alongside the consultants and are reporting alongside consultants and learning along the way with feedback. Some of the newer training schemes follow an academy model, which is where the first 2 years are spent within an academy with focused teaching around different modalities and around medical physics and anatomy to help candidates pass the first part of their FRCR exam prior to going into the hospital setting. Feedback with regard to the academy method of training has been very positive, as all the trainees get a uniform amount of teaching throughout the first 2 years, and what it means is that they are definitely going to be ready when they come to the point of being in hospital after 3 years, while in the traditional apprenticeship model, depending on where you're placed, the experience that you might get can be slightly different. The radiology training programme in the UK is 5 years, and there's a gradual progression through the years. So when you start in year 1, there is very limited experience of radiology going into the programme. Therefore, you're really starting from the basics. And the aim of the year is to become competent in general plain film reporting, be able to carry out fluoroscopy investigations, basic ultrasound investigations including abdomen, urinary tract and DVT scans, and getting a good grasp of emergency CT. And the reporting that we carry out in the first year is mainly focused on inpatient and accident and emergency work. Also during the first year we are expected to complete the first part of the FRCR examination, which I'll talk about a little bit later. In the second year of radiology training we start out of hours on call, and we start doing independent reporting of plain films. We also start doing more MRI reporting, and during this period of time between years 2 and 3 we go through subspecialist blocks which follow the modules of the FRCR 2A. During the second year we're expected to complete 4 modules of the FRCR 2A, again which I'll explain about a bit further later on. In year 3 we continue to complete the subspecialist modules. We aim to get about 90% of our curriculum that's outlined in an online portfolio signed off by consultants who are training us, and we also are expected to complete the remaining 2A modules. After completing our 3 years of general training, we then choose our subspecialist interest, and in year 4 we start subspecialist training, and what this means is 6 of the weekly 10 sessions are focused on subspecialist training. In year 4 we're also expected to complete our final FRCR exam, and throughout year 4 and 5 we continue subspecialist training and become more and more competent in our general work. While doing subspecialist training we are constantly told that it's really important for us as a subspecialist radiologist to be significantly better at looking at the imaging for that speciality than the clinicians, so we really add a lot of value and are a really valuable resource at the multidisciplinary team meeting. At the start of our training we are signed up onto an NHS e-portfolio focused on radiology training, and within this there is a radiology curriculum which initially has a core curriculum which we are required to complete during the first 3 years, and then goes on to have more subspecialist curriculums which you pick specific ones to complete during years 4 and 5. During our training we are expected to develop proof of different things that we have done and then attach these to parts of the curriculum, and then during our appraisals the curriculum is signed off, and the aim is by the end of year 3 to have 90% of the general curriculum signed off, and this can include anything from any of the subspecialities, but also things related to research, management, and general tasks that a doctor should know, including consent, infection control, hand washing, and other things like that. By the end of 5 years training, we are expected to have completed all of the general curriculum and all of the selected subspecialist curriculum that we have chosen. Proof of what we're doing throughout a year is collected via a range of different workplace-based assessments. Every year we are required to carry out 6 mini IPEX assessments, which is where we have done a report and had it checked by a consultant, and they will then feedback via this form. We have to carry out 6 RAD-DOPs, which is 6 procedures that we've carried out under supervision of a consultant, and again they fill out a form and provide feedback on that. We are required to complete 1 audit assessment per year, 1 teaching session that is supervised by a consultant per year, a multi-source feedback, which is where we hand out 10 feedback forms to a number of different staff throughout the department who can feedback on how we've been behaving throughout that placement. We're also required to do an observed MDT session with a consultant and required to get feedback on that as well. All of these assessments can then be linked to parts of the curriculum in our portfolio so that the consultants who are appraising us can then sign off that specific curriculum point. The electronic portfolio provides us with proof that we can then take on in the future, and a collated version of all the feedback that we received over the period of 5 years, so that when we go for job interviews or decide to go abroad for jobs, we have this as proof of what we've done during our training. Regular appraisal is considered very important throughout our radiology training, and for the training program we are allocated an overall educational supervisor who is with us for the 5-year period, and we meet this person normally 3 times during the year, once at the start of the year, once at the middle of the year, and once at the end of the year. And what this enables us to do is get some mentoring and guidance from this person, but also so that someone can keep an eye on us and see that we are getting parts of our curriculum signed off and can highlight if there are any gaps in our progress. In addition, during each rotation, which is normally 6 months, we are allocated a clinical supervisor, and with this clinical supervisor we also have 3 meetings, one at the start of the placement, one at the middle of the placement, and one at the end of the placement. And this is to ensure that we have achieved what we set out at the start of the placement. During each clinical placement, we are required to set out a personal development plan in our portfolio, and these are all the things that we are hoping to achieve during this placement. And during our end of clinical placement meetings, these supervisors particularly look at this personal development plan to ensure that we have completed the tasks that we set out at the start of the placement. One of the main focuses throughout our training is completing the FRCR exams, and I just want to spend some time going through each part of the FRCR exam. So during the first year we're required to sit the first part of the FRCR, and this is 2 modules. There is a physics exam, which is a true or false exam and is quite significantly based on a medical physics book written by Farr. In addition, there is a radiological anatomy exam, and what this consists of is 100 questions with arrows pointing towards individual anatomical structures in the body, and this could be a muscle on an MRI scan, it could be an artery on an angiogram, or a structure like a pancreas on an ultrasound scan. And it's really important to have a really good rounded knowledge of your anatomy to be able to pass that exam, as the pass mark is quite high. After completing the first part of the FRCR, you then go on to the modules of the final FRCR Part A, and there are 6 clinical modules. These are the chest, cardiac and interventional module, the musculoskeletal module, the gastrointestinal module, the GU breast and adrenal module, the neuroradiology and head and neck module, and the pediatrics module. Each of these exams have 75 single best answer questions, and they are very clinical scenario questions. Therefore, the best way to prepare for these, as well as doing lots of question books, is to spend time in the clinical environment. And generally, people who have completed the clinical placement for that subspecialty do very well in these exams and pass. However, it is not unusual for people to have to sit modules 2 or 3 times due to the difficulty of these exams. After completing all 6 of the FRCR 2A modules, you are then eligible to go on to sit the FRCR Part 2B. However, you have to have completed 3 years of radiology training prior to being able to sit this exam. Therefore, the earliest time for us to sit the exam is at the start of our 4th year. The final FRCR exam is done at the Royal College of Radiologists and involves 3 parts. The first part is a rapid reporting exam, the second part is a long case exam, and the third part, which we all dread, is the Viva exam, where we are shown a selection of plain films and CTs in front of another consultant radiologist and asked to discuss these areas. The key to success in the FRCR examinations, as well as having a good knowledge, is to have a good exam technique. And the best way to do this is to do lots of practice questions for the first part and the 2A modules, as there are a selection of books and online resources. The exams, especially the final parts 2A and 2B, are very clinical, and therefore being present and doing lots of reporting is the best way to pass these exams. In the UK, for the final part, there are a selection of courses that people tend to go on to help them pass this final part of the exam, as it's very clear that exam technique and knowing how to play the game in the exam is the way that people pass this. As a UK-based radiology trainee, there is an extremely useful resource that is available to us, and this is a resource called RITI. This resource has a number of e-learning modules on numerous different radiology topics, and the aim of this e-learning package is to cover the full breadth of the radiology curriculum that is outlined to us, and this is available to every radiology trainee in the UK, and I expect that it's possible to access this via outside training schemes via a membership. In our second year of radiology training, we are given the responsibility of starting out of hours on calls, and what this means is that we are required to take all the referrals for emergency imaging and also report all mainly CT investigations, and following this, within 24 hours the consultant is able to check these images and adds an addendum if there are any changes that are required. There is always a consultant available by phone, and they normally have access to the images via a teleradiology system if we require any help. For many radiology trainees, this period of time is a steep learning curve, and the key is learning how to make decisions and to become confident in all our diagnoses. And over the period of time, we gain experience and continue to get better at emergency imaging while on call. After completing 5 years of radiology training in the UK and receiving the certificate of completion of training, a number of trainees choose to go abroad and complete subspecialist fellowships in very reputable centres. What this does is gives extra experience, but also gives an insight into the different ways that people work, and can be very advantageous when coming back to regions where you can set up new services that you've seen elsewhere in other centres. For interventional radiology, a 6th year of training is recommended, and if a 6th year is carried out on a UK-based training scheme, it means that trainees can get a certificate for completion of training in diagnostic and interventional radiology rather than just in diagnostic radiology, which you receive in 5 years. My final slide is how can we collaborate. So I've given you a bit of an insight into how the training is in the UK, but I really want to hear back from you about how the training is in the different nations across Africa, and if there's anything I can do or the other UK specialists can do to assist you in your training. This could come in the form of combined teaching image banks that can be set up on the internet. It could be that online courses or courses in person are delivered in your respective nations. Thank you very much for taking the time to come and listen to my talk, even though I've done it virtually. I really hope that you drew some good knowledge from what I've said, and again, I'm really keen for you to get in touch with me. Following this, the final slide will have my contact details, it will have my Twitter link, my LinkedIn link, and my email address. So feel free to get in touch, and I'll try and respond to everyone in good time. And as I said, I'm really keen to form links between the UK and the African nations.